So sentinel node biopsy is an established technique in staging of melanoma. The sentinel node is the hypothetical first lymph node or group draining a cancer, and it was probably Seaman and Powers that were the first authors to describe it using a technique in 1955 using radiolabeled gold. Gould, in 1960, described its use in head and neck cancer and stated that the histology of the node may guide the surgeon in decisions concerning the necessity of doing a radical neck dissection, because up to that point and continuing melanoma, a prophylactic lymph node dissection was gold standard. In 1977, Cabanis established a technique in penile carcinoma, but it was in 1992 that Morton highlighted its use in melanoma. Now, really, it's a two-stage technique. The first in nuclear medicine pre-surgery. Technetium-99 is injected intradermally around the melanoma scar. The radioactive isotope shows on X-ray and it's tracked from the melanoma scar, where in this case a large hotspot's noted, through the lymphatics to the regional node basin. And in this case, one obvious hotspot and one minor hotspot's identified in the right axilla. Multiple nodes can be identified at scanning in multiple node basins, and this kind of depends on the site of the melanoma scar and the size. In some cases, interval nodes are spotted, and in many, the trace can be seen going between the scar and the hotspot. This information is used at surgery, and the nuclear medicine scan can be done on the day of surgery or the day before. At surgery, either under a local anaesthetic or general anaesthetic, patent blue dye around 1 ml is injected into the scar at the same point as the previous technetium-99. Using the markings from the nuclear medicine scan and the gamma probe, the site of the sentinel node is identified. A small scar is placed either at the site of the markings or at a planning site for future surgery. With the use of the probe and the blue dye, the sentinel node can be identified and removed. A wide local excision is performed at the same time. And if the wide local excision is close to the sentinel node, I'd recommend removing that first, as the scatter from the technetium-99 can interfere with the accuracy of identifying the sentinel node using the gamma probe. Risks are divided into standard for any surgical procedure, so scar, bleeding, hematoma, infection and delayed healing, and specific to sentinel node biopsy itself, including seroma, which may necessitate a stay in hospital and further surgery, lymphedema, which is rare, nerve injury, again rare, and recurrence and blue dye allergy. Blue dye is used off license, so it's important to mention this. The risks of the blue dye allergy in the literature are quoted around 1 in 500. Why is it off license? Well, we know it works, and no trial has ever been done to prove its efficacy compared to another drug. And using off license means that the vial for each patient must be documented, including batch numbers and expiry dates. Other things to mention that is a negative sentinel node biopsy does not preclude recurrence. It just lowers the risk for that patient compared to if it came back positive. So why offer it? Well, it's an established technique across the world, and it gives the patient and the treating clinician a bit more information about their melanoma status when scans and blood tests aren't great. If it's negative, it puts patients in a lower risk group of getting recurrence compared to if it's positive. If it's positive, you've not only removed that microscopic disease, but the patient may be suitable for adjuvant therapy, and in some cases, a therapeutic lymph node dissection. It does convert a local anaesthetic operation to usually a general anaesthetic or regional anaesthetic. And you do have to ask your patient, what would they do with the information? If they were given treatment after this, would they be fit for it, and would they want it?